Good morning, everybody. Thank you very much to the organizers and especially to Helena, who I've known for many years now, for inviting me to come and join you this morning. It is a huge pleasure for me. I am only very sorry that I cannot speak to you in your own language. However, I believe that in your packs you have the slides that I'm going to present, and they've all been translated. So hopefully you can join this one. Okay. So we have already heard quite a lot about European Reference Networks, or ERNs, today. So this is a heartening thing for me because ERNs have been a big part of my professional life for the last 6 years. I've been involved in several projects which helped to get these networks up and running. So I'm very proud of the ERNs and the success story that it's been so far. So what I want to do today is just to give you a brief outline of what the networks are and where are we with the ERNs, because some people here I think will know very well, others may not be so familiar. I'll talk a little bit about patient involvement in ERNs. And then I will try to summarize very briefly, because we would be here for a long time if I did this properly. I will try to summarize some of the advantages or the added value of ERNs, both at the European level, so what they can do for Europe, but then start to think about some of the points that countries can explore on the ground. Okay, so ERNs. What is an ERN? An ERN is basically a network which connects together providers of highly specialized healthcare. So these are what we have always called centers of expertise in the rare disease field. And these centers should all be operating in domains where the expertise and the patients are scarce. So rare diseases are not the only beneficiary, but they are a very important, very obvious beneficiary. The concept of ERNs did not come from nowhere. It's been around for well over 10 years now. But it was really 2011 when this very important directive, the Cross-Border Healthcare Directive, was published. There was a little section in here which explained that for very rare diseases, sometimes you need to think about a networking approach across borders where the patients don't have to travel. So ERNs are really about the expertise traveling rather than the patients. So we're talking about virtual healthcare. Care is the important word here. In Europe, we have had different sorts of networks in the research field for quite a long time. But this is the first time that we have something across Europe which is first and foremost about care. If ERNs are done well, they can be a great equalizer for patients, because what they will mean in time is that no matter where you happen to live in Europe, unless you're in my country, in which case you could be in trouble, wherever else you live in Europe, you will not be disadvantaged by not happening to live next door to the best expert in your disease. And I'll talk more about how this will work. This is a little snapshot of what the environment looked like for rare disease projects before ERNs, what we call the pilot networks. And each of these, I have a pointer, let me see if it works. No, it doesn't matter. Each of these were projects, so set up maybe for 2 years, 3 years at a time. They were funded by the European Commission. And the important thing is that most of them, as well as being temporary, they were set up for specific diseases or specific groups of diseases. So epidermolysis bullosa, Duchenne muscular dystrophy, cystic fibrosis. So what ERNs were going to offer was, in time, a move away from that traditional project funding model. And they had different advantages, or were hoped to have different advantages for different groups of people. So for patients, as I explained, the big hope is that ERNs will in time reduce inequalities for patients. So it won't matter that you don't live next to the leading center for your condition. You also will not be disadvantaged by not being one of these diseases that appeared on the former slide. For the clinicians who were involved in these sorts of projects that I just showed you, which were very successful, ERNs would be a way to consolidate and to sustain the work that they were doing. So they wouldn't be limited by a couple of years of funding. They could try to put things in place that would be lasting and that would be a formal recognition of their expertise. But importantly, for the communities where there were no projects, for the diseases which are maybe too rare or which didn't have a clinician who was going out getting funding, it would mean that in time, the ERNs would address those conditions too, and we would start to build expertise. So it wouldn't just be a case of whoever shouts the loudest, their disease gets all the funding and all the support. And there was also a lot of interest from industry, from regulators, from health technology assessment bodies, about the potential of having these structures at European level, which are permanent and which bring together the creme de la creme, the best of the best in expertise. So, what do ERNs have to do? They have many roles. They have to have the knowledge and the expertise to diagnose, follow up, and manage patients. They need to show evidence of good outcomes. They need to have a multidisciplinary approach. This is extremely important for rare diseases, and we heard this from Raquel's presentation earlier today. They have to have the capacity to produce good practice guidelines. They need to collaborate with other centers of expertise and with other networks, and that's really important because not every center of expertise in Europe that looks at rare disease patients will be a full member of an ERN. It's not supposed to be a club where every center is involved, but rather your country will link into the ERNs through a limited and manageable number of centers. This was the idea. They also have to do research, teaching, and training. So this is a hugely complicated list. It's very ambitious. And for this reason, our poor 24 ERN coordinators, or the leaders, are actually going a little bit crazy because they've signed up to something which is very, very substantial. So, where are we today? At the very end of 2016 and the beginning of 2017, 24 ERNs were officially approved. Now, the numbers of centers involved is really quite considerable. So, approximately 370 hospitals and almost 1,000 highly specialized units are involved because the big hospitals will have different centers of expertise within them with expertise in different areas. So somewhere like Erasmus will have maybe a rare liver center and a rare renal center and a rare eye disease center. So all of those units can participate. We have 26 countries involved so far, and the ERNs are overseen by a special executive governing body, and this is the BOMS, or the Board of Member States of ERNs. Each country has a representative, and your representative, as you probably know, is Helena. The coordinating centers of these 24 networks at the moment are based in 7 countries, but this will change because of a certain word that I will not utter today. The coverage of the ERNs will increase. They will grow. How they will grow, how new members will join, is still being debated because some of the networks are very, very big, and there are real discussions as to how and where we should add new members. I can talk more about this later if that's helpful. So, this is an old slide. This was a slide that my project, RD Action, produced, but you can read about all these different networks in many different websites. So you can see here the network names. So we have BOND, for instance. They all have these little acronyms. And BOND is the ERN for rare bone disease. Now, one of the big advantages of the ERNs is that they are set up at this broad level. So the Rare Bone Disorder Network will in time be supposed to have expertise and take care of diseases, all the diseases under that heading. So Rare Metabolic Network should not just be about a single metabolic disease or a group of metabolic diseases, but should be about all diseases. And this is where we have a lot of promise and potential in the ERNs. I would also encourage you all to have a look at the very up-to-date European Commission website, where you can find lots of information on the networks. So you can search here, and you can find a folder which lists all the ERN members in each network. So you can search for the bone network, and you can find where all of those centers are across Europe. You can also search by country. So you can search for Finland. This is probably a little bit small, but you hopefully have this in your pack. And you can see who your representative is in the board of member states. You can see which of your Finnish centers are members and of which networks they happen to be members. So there's really good information out there. You can also now go to the direct websites of all 24 ERNs, and they have some very good resources on there. So this is how some of them are starting to show what they're doing and who's involved. This is for the rare heart ERN. So you can see they've nicely used the little hearts to show where their member centers are. Some of the networks have even more elaborate and complex and interactive websites. So the EndoERN is for endocrine diseases. This is the biggest network. It has 71 member centers, which is a lot. So what they've done is you can go on their website and you can see how many centers are in each country. And then you can click on these in more detail. So for example, the Erasmus Hospital, it gives you all the contact information for where to go. And it also tells you what types of endocrine diseases that hospital is specialized in. So there's lots of good information out there now as the ERNs start to work. So what are the networks actually doing in 2018? Well, I could spend a lot of time talking about this. So instead, I'm going to point you towards a report that I spent a lot of the summer producing, which is a big report which summarizes lots of things that are happening across the rare disease field in Europe. And you can have all of these slides, you can follow these links, of course. But just as a summary, money is a main issue, is a key issue for the ERNs. Looking after networks with 71 centers costs quite a lot of money. So currently, the coordinators are trying to find funding solutions to support those coordination teams. And things are getting better, but it's a little bit step by step. An important development is that the 24 coordinators, the leaders of the ERNs, are starting to forge an identity as a group. So they're setting up some new governance structures to manage this great work. So for instance, this is just a little table showing some of the working groups that the coordinators have formed across the ERNs. So for example, research. All the ERNs have to do research, so it makes sense that they work together to see how they can add value and what they can do which is better than what went before. So there is a research working group which brings together representatives from all of the coordinators, and it's basically trying to stop each network from reinventing the wheel and doing things separately. It's trying to bring some sort of collaboration to the process. I'm going to go through this slide very quickly, although it's one that I love, because this is basically the results of the last 3 years of my life. Our project, RD Action, finished this summer, but we did a lot of work with the ERNs to try to help them to address their shared challenges in some sort of a logical, harmonious, collaborative way, to get them to work together, basically. And our main way of doing this was organizing a series of workshops to explore how ERNs can do X, Y, and Z. So how can ERNs generate clinical practice guidelines? How can ERNs provide virtual healthcare? What systems can they use? You can find out all about this work here if you are interested. Okay, patient-centeredness and patient empowerment. I've stolen this slide from my colleague Matt Johnson at Eurodis. And I'm only going to introduce this in one slide, but again, we could talk for a very long time about this. The good thing about ERNs, one of the good things, is that they were actually, the idea came from patients. So Eurodis, the European was really involved going back 10 years or more in lobbying. So they've been very involved in this. And when we were putting together an initiative where including patients was kind of a tick box exercise. There should be meaningful involvement. So one way that Eurodis has come up with to try to ensure that is by creating EPAGs, European Patient Advisory Groups. So these are forums. There are 24 of them. There is one for each network. And you have individual patients joining as EPAGs each of these forums. One of the positives, I think, about the networks is that for some of the ERNs, they had patients involved actually right from the beginning in drafting the applications, which was really important, and that was a good practice that we wanted to see continued. And today there are over 350 elected EPAG representatives who are standing as individuals, and they are representing their broad disease community. For example, you may have a patient from the rare blindness, the retinitis pigmentosa community. This person is serving as an EPAG for the rare eye ERN, meaning she tries to represent all patients with rare eye conditions, not just her own. And people are involved in many active ways within the networks. So they are serving on the governance bodies, they're serving on the executive boards, they're joining the advisory groups. So this is quite a good way for interested patients or patient representatives to participate. I've put the link on the bottom where you can find a lot more information about this. If you're interested in joining with the EPAGs or seeing how they're working, then you can find this out. Okay, what's the point of all this? I've told you what ERNs are and a little bit about where they've come from, but what are they actually going to do, or what are they doing now? So there are lots of advantages, lots of added value of ERNs at European level. Partially because they are operating at this European level. We've never had anything like this before for healthcare. It's also important to note that the European Commission is very supported and very invested in the ERNs. ERNs are a great success story across Europe. You have this real pan-European collaboration. So the Commission likes the networks and seems very likely to continue to support these, because they should, in theory at least, be permanent. So these are not projects that are going to go away after a few years. Providing the networks get through all of their evaluations, they will be around for a very long time. They're also very comprehensive. They're comprehensive in their age. So for instance, we'll go back to rare bone again. The Rare Bone Network doesn't just look at pediatric bone diseases or adult bone diseases. It looks at the whole spectrum. And that's very important because that transition of care is such a difficult thing to manage in a lot of rare disease centers. They're also comprehensive in their scope. But because the networks have so many responsibilities, remember that slide I showed with all the different duties, it means that potentially they can add value or have benefits in many different ways. So I'm just going to cover one or two of these in a little bit more detail. I won't go through everything, but you have the slides, so you can have a look in your own time. These are not pictures from ERN consultations. These are just Google images of how telehealth and e-health is sometimes done. But one of the big added advantages of ERNs is that patients with very complex conditions can be referred for shared care via an ERN. So what this means is that your local healthcare team can refer your case, if you consent, to the ERN, where you can get together a panel of experts from all the different centers involved in that ERN, and they can come together to discuss a patient case. They could discuss how to diagnose your disease, what kind of tests are needed, what sort of explorations. They could provide a second opinion on how best to manage your symptoms, on any potential treatments. So all of the healthcare providers, all of the 1,000 units which are members of ERNs, now have access to a shared IT system, what we call a CPMS, or Clinical Patient Management System. And that is one unique system which all patient cases can be referred to. This slide is now out of date. We're actually, I think, about 300 patients have now been referred through this system. So the potential to do virtual care across borders in a safe and secure way, this is something that's never really been done before. So this is a huge area where the networks can add value. This is a very busy slide, lots of words. So I'm going to summarize just by saying that data is extremely precious in the rare disease field. We need to collect and we need to pool and share as much data as possible to let us do many, many things, even to understand the natural history or the natural course of development of a disease. You have to build that critical mass of patient data. So ERNs offer a huge potential to do that, for example, through the setting up or the expanding of registries, patient registries. Third and final example of how ERNs can add value at the European level is around generating knowledge, and this is a very broad term. ERNs, having this potential to collect precious data sources and to share it amongst themselves under certain careful conditions, will be in a great position to generate new knowledge on diseases, on treatment approaches, etc. You have the opportunity to get all of these world-leading clinicians working together with patients at the center of what they do, and it gives you that chance just to look at what works. Does a particular treatment, a particular type of intervention actually benefit patients? For example, Duchenne clinicians, Duchenne muscular dystrophy clinicians, came together, they pooled data from many centers across Europe, and they realized that if patients were taking steroids, a particular medication, the boys were ambulant, they were walking a lot longer than in the countries where the boys were not given steroids. So simply by getting people together, networking and sharing data, you can see what works for rare diseases. And the ERNs give us the chance to actually capture that, what works, into useful outputs like clinical practice guidelines or care management guidelines. So there's a great opportunity, I think, in the ERNs, working as they do across all of our countries, to try and set the standard. You know, what is the ideal gold standard of care for my condition? What's the best way to diagnose my condition? Now, all of that is fairly pointless if you cannot then translate it onto the national level. Because although the ERNs are operating across Europe, they are all rooted in healthcare centres, in centres of expertise in the country. So patients, overwhelmingly, yes, if you have a complex case, you may be referred for some virtual shared consultation through the networks, but day to day, you will still receive your care on the ground, meaning locally to where you live. Your local doctors will still be providing your care. So it's really important to find a way to translate those benefits into a national reality. So this is how I see this. ERNs are up here. They're branching across ideally all of our countries. They're involving a number of centres from each country in a little hub and spoke model. So the ERNs set the standard. They identify and they agree good practices, whether it's around data sharing or delivering care or diagnostics. They define what the good standards should be, and then the healthcare providers, the centres of expertise, which are members of those networks and are here, outside of us, here in Helsinki and elsewhere, they ideally should be embedding these practices in their daily practice. Then, through this hub and spoke system I mentioned, the centres which are full members of the ERNs should be working and collaborating and communicating with all of the other healthcare centres in this case, Finland, to share those practices so that ideally they become spread throughout the whole health and social systems in each country. But this shouldn't just be a top-down approach. These centres on the ground across all of Finland should also be feeding back their experiences and their preferences and their knowledge of what works for patients back into the ERNs. So it should be a kind of a virtuous circle between the national and the European level. Okay, I think I only have a few minutes left, so I'm going to go quite quickly through these last slides. So what are some of the challenges in integrating ERNs at national level? There are lots of challenges, but we have to try to find a way forward. Otherwise, if the ERNs never really translate to any benefits on the ground, there's no point. It's all been a nice exercise, but there's no real benefit. So, ERNs should not destroy, they should not bulldoze the existing structures that countries have at national level. So if you have a national network, for example, for a particular group of diseases, that national network in your country should stay. Good example is Italy. France, they have national networks for rare diseases already. The ERNs will not push those aside, the ERNs should work with those. So, good thing about Finland, it is easier to see how the ERNs can really add value if your country has done a good job in mapping out and formally designating where your expertise is. Because if you don't know where your expertise is in your country, and you don't know what expertise you have, it's very hard to see how patients can actually engage with ERNs and how professionals can engage. So one of the big benefits for me, actually, is that ERNs should help so-called centers of expertise to really be centers of expertise. And to be a real center of expertise in rare diseases, we have all of these recommendations which countries have agreed at European level. It's very important not just to look at the medical side, but to look at the more integrated care, the more holistic side of rare diseases. That's what our centers of expertise should be doing. So hopefully ERNs can help to get some of these practices working on the ground. Again, it's all very well for the ERNs to set the standard and to say what works, to say what is the best way of pooling data, and to define clinical practice guidelines. But if your centers on the ground in our countries don't want to use those clinical practice guidelines, if the ERN says, for example, my neuromuscular example from before, if the ERN says it's a very good practice for patients with Duchenne muscular dystrophy to receive steroids, it means they can walk for several years longer than the boys who don't have them. If countries don't take notice of that, and they don't do anything in their system to use that knowledge, then we've missed a big opportunity. Again, where is the point? So we need to work very hard in all of our countries to build that trust, because the countries and the authorities who make the decision on how and what care is provided, they have to have a trust that actually what this ERN is saying is good, that this information and this shared knowledge is actually worthwhile. And this is a very difficult thing for countries to do, because healthcare has always been a national responsibility, a national priority. So we need to work, and it will take some time. So this is my final slide. I know that you're all meeting today to talk about your next national plan, which is wonderful, actually, because quite a lot of our countries, their national plans and strategies for rare diseases are now either out of date or they're coming out of date. And a lot of countries have not yet thought about their second plan or their third plan. So I think Finland is doing a fantastic job here. What I wanted to say is that when we're talking about ERNs are extremely important. They're a really important issue in rare diseases, but they're not everything. So ERNs will not address, and they will not solve every rare disease problem in your country. They can add value, but you will always have, for example, centers and professionals and laboratories who are not formally part of an ERN. So you need to think about how you engage all of those different actors. It's really important that as the countries are continuing to implement or update their plans and strategies, that they try to think about how they could include ERNs. What kind of pathways are patients going to take through the system? What kind of outputs will come out of the ERNs? And how might the national authorities be willing to use those? Again, going back to things like guidelines. So, it's fantastic that you're thinking at this point on how to include ERNs into the next national plan, because as I said, we're at a time where many of our countries, this is a little bit small, but you can see it on your slides later, many of our countries are coming to the end of their national plans and strategies. And because these documents, these policies were written and adopted before the ERNs, I think all of our countries are trying to tackle how we can update these and how we can bring the ERNs from something that exists up here to something that exists down here on the ground. So thank you very much for allowing me to share a few thoughts with you this morning, and I wish you a successful conference. Thank you.